So welcome back, everybody. I'm going to hand you over to Dr. Jacqueline Tay, who's going to do a quick introduction, and then we will talk through some of the questions that have already started going in the chat. So over to you, Dr. Tay.
Morning, everyone. I'm Jackie Tay. I'm one of the gynecologists. I do obstetrics as well here at LTHT. I suppose as part of gynecology, we do deal with the menopause. So I guess I'm here. When I saw this event, I thought, oh, it might be quite good to just run a session where people might have lots of questions to ask about the menopause. So I think I can see some questions coming in already. And I think someone said on one of the chats to say your GP won't declare your menopause till you've not had a period for a year, which is right. So if we can just rewind a little bit to, I suppose, definitions and how we make the diagnosis. So quite simply, regardless of age of the person who stopped menstruating, we say that the menopause is when you have not had a menstrual bleed for a full 12 months. Okay, so it might be 8 months, it might be 9 months, it might be 10 months, but technically the definition of a menopause is when there's been no period for 12 months. And just common things being common, women in their 40s, late 40s, early 50s are much more likely to go through the menopause naturally. So we say that the average age of the menopause in the UK anyway is 51, 52. In my practice, I think I've seen over the years the age of the menopause creeping up. So women now are a little bit older, so it's not uncommon for us to still see women at 54, 55 still menstruating. If you have a young woman who stopped having periods, then we would call that a premature menopause, premature being quite specific, so under the age of 35 or 40. But premature ovarian failure is the other term that you might hear people use, because actually what is the menopause? So, you know, as an external sign, we have menstruation monthly usually, some people longer cycles, some people shorter cycles, but bleeding is just an external sign of actually the ovarian function. So when the ovaries stop functioning, or when the ovaries stop ovulating, stop producing eggs, that's when we stop having periods. So bleeding is an indirect sign that our ovaries are no longer working. So the flushes and all the other menopausal symptoms that come with no periods, it's not because of no periods, it's because the ovaries have started to become less active. So as we approach the menopause, the ovaries gradually become less active. So ovulation might no longer be regular, it might not be every month, it might be every other month. And that's why periods become very irregular and become hit and miss, because ovulation has stopped being regular. So it's actually our ovaries that give up working, and that's why our menstrual cycles change, and that's why bleeding stops. So someone has said your GP will not declare you in menopause until you haven't had a period for a year is very, very true. And you don't have to wait till your periods stop in order to start HRT. So HRT, as the name says, hormone replacement, is to replace what is lacking, which is mainly estrogen. That's the main hormone that produces all the symptoms that everyone's well aware of, that cause us to sweat, poor sleep, brain fog, stiff joints, tearfulness, feeling emotional, irrational even, all those lovely symptoms that everybody talks about. Does that sort of set the scene a little bit more? So doing blood tests doesn't necessarily help. And in fact, you don't really need to have a blood test to confirm whether or not you're menopausal or perimenopausal. So that's the other term you might hear people say, that time leading up to the menopause, where your ovarian function is less efficient, less regular, and so your estrogen levels can fluctuate from month to month. So you might have some months where you feel fine, the next few months you're sweating a lot, not sleeping very well, and then it's fine again. So that's when you tend to miss periods. They come back, they disappear, they come back. So the British Menopause Society actually doesn't recommend routinely checking your bloods unless the woman is very young. So if you're 35, under 40, your period suddenly stop. I think that's really important because there might be other reasons why your periods have stopped. But for most women, I would say from mid-40 onwards, if you're describing menopausal symptoms, then it's not unreasonable to think about using HRT.
That's really interesting, Dr. Tay. I think because a lot of people automatically presume I need a blood test to confirm this, and you've kind of said that that's absolutely not the case. So I think that's really interesting for people. Could we talk a little bit about HRT? There's a couple of things gone in the chat around, are there any kind of restrictions? So somebody's mentioned if you have clotting problems, for example, or is there an age restriction? Could we just talk a little bit around HRT and the myth busting, I suppose, around some of that?
Okay, so HRT, for any woman who still has a uterus, and this is the kind of crucial fact, and there's no way around it. If you've got a uterus, then you must take combined HRT. So that means you must take estrogen and progesterone. So even if your periods have stopped and you're coming into menopause later, you still have to have combined HRT. For a lot of women who are starting HRT, it's before their periods have stopped. So in that group of women who are still having periods, even if it's one period every 6 months or one period every 3 months, you need to have regular bleeding. So there's basically what I would say two types of HRT. It's still estrogen and progesterone, but the usual combined estrogen and progesterone that gives a monthly bleed is what I call a cyclical HRT preparation. So women who are still having periods and women who are under the age of 54, this is the recommendation in the BNF, you should ideally take a combined cyclical HRT. Now, it might be upsetting to learn that you're going to go back to having monthly periods, but that is kind of what the cyclical HRT will do. And that is to protect the lining of the womb. So that's important that you don't expose the womb lining to estrogen only, because estrogen over a long period of time at high doses can induce abnormalities within the womb lining. Over the age of 54, and for women who have stopped periods for at least 12 months, so we're saying that they are menopausal, in the menopause, then you take a combined HRT, which is a continuous combined HRT. So this means there's a fixed dose of estrogen and progesterone in that HRT, and you should not need and you should not have any monthly bleeding. How you take that HRT is very much a matter of personal preference, but also your medical history. So HRT comes in the form of tablets, in the form of patches, so what we call transdermal patches. It can also be split. So there was somebody asking about the Mirena system. So the Mirena system is the progesterone part of your HRT. You can then use the estrogen either as a tablet, as a patch, or as a gel. So it gets very, very confusing if you try and say, oh, I want a patch that's got combination or no combination, or give me a bleed or give me no bleed. So you just have to kind of try and work it out sensibly. And again, the British Menopause Society website will give that sort of information. But for a lot of women who have abnormal bleeding on HRT, it's usually because they're not on the right dose or they're not on the right preparation. They've started the continuous combined preparation too early, so too young, and your body is probably still trying to have menstrual cycles, and you're then taking hormones to suppress that or work against that, and you'll end up having irregular bleeding. So it may be you need to go step back and go on to monthly bleed, HRT, unfortunately, and then eventually, you know, when you're over 54 or when your periods have stopped, then take the continuous combined no bleed preparation. I think somebody asked about clotting. Is that right? If you've got blood clotting. So that's a tricky one, because actually we need to know the reason for the blood clotting, you know, your kind of more personal history. It does not absolutely exclude HRT, but the worry with HRT is it can increase clotting. The best preparation for reducing the risk of clotting on HRT is the transdermal route. So that's usually the patch or the gel. Gel, there's only estrogen gel. There is as yet no progesterone gel that I'm aware of. So it would be estrogen gel with progesterone in a different way, which could be the Mirena system. Or it could be a micronized progesterone, which is a more specialized type of progesterone. So if you've got clotting in your history, or you've had a stroke, or whatever, you've had a DVT, then you really probably need to go to a more specialized menopause service. And Leeds, we're lucky, we've got a community menopause service. Dr. Spencer is our community menopause specialist, and she works from the Meanwood Health Centre. So your GP should be able to refer you to that specialist service. So anybody that's had some kind of history that may contraindicate the use of hormones and needs to go and see that, needs to be referred to the menopause service to see Dr. Spencer, really.
Thank you, Dr. Tay. And there's a couple of things coming up on the point of those ladies that are currently using the Mirena coil. So with the Mirena coil, periods tend to stop.
Yeah.
What would your advice be to somebody who maybe thinks they potentially could be perimenopausal but has the Mirena coil, so isn't quite sure?
Yeah, so the difficulty with the Mirena is if your period stopped, then you think, am I in the menopause, or have my period stopped because I've got the Mirena? In some ways, it doesn't really matter if you are symptomatic and you're of that right age group, where you think, yeah, I'm probably due to be in the menopause. And again, it's quite common that we use the Mirena to treat heavy menstrual bleeding, but being perimenopausal tends to produce heavy menstrual bleeding. So you're kind of chicken and egg situation. So you can use the Mirena as part of your HRT. So you can then add estrogen, either as a patch or as a tablet. And the risk is you may start bleeding again, but there is a way of managing that bleeding, either cyclically or just using a low dose estrogen to treat the menopause symptoms, but not enough really to induce bleeding again. So it may take a little bit of what I call fiddling around with the right dose, the right route of estrogen. And that's where you need to be patient with your GP, actually. to see what actually works best for you. I think someone has put down, you've been put on antidepressants due to not being able to take HRT. So yes, so we do occasionally use antidepressants to treat the kind of, I would say, the emotional mental health side of the menopausal symptoms. We can also use something called clonidine to treat hot sweats and flushes. So if you can't take HRT, or you don't want to take HRT, but you think, actually, I'm sweating a lot, hot flushes, you can try clonidine. Again, I'm not sure that many GPs would use that, but it is something that certainly I would prescribe, and it can work quite well. So it's not HRT, it's not hormonal.
Okay, brilliant. Thank you. And just while we're talking about HRT, there's been another question in the chat. Does HRT cause breast cancer?
It does. So there's no doubt with all medicines, and particularly hormone medication, there are risks. Breast cancer is a small, but it's a real risk for women on HRT. Other things include thrombosis. So if you've had a DVT in the past, as I say, it doesn't mean that you can't, but you should seek specialist advice. Blood pressure sometimes can be affected. So if your blood pressure is controlled, then chances are you will be able to continue controlling your blood pressure. But I know of patients who've started HRT and then develop blood pressure. So then it's a decision whether you want to then control the blood pressure and continue on HRT, or stop taking HRT. Diabetes is not a contraindication. So again, I've been asked, I've got diabetes, can I have HRT, or my GP won't prescribe HRT. Diabetes is not an absolute contraindication, but indirectly things like your BMI, your smoking, blood pressure control, these are all things that have to be taken into consideration when we are assessing whether HRT is suitable. So it's like being on the contraceptive pill. Your GP will ask questions about your weight, your smoking, is there a family history of, blood clots and all that sort of thing. All those questions are relevant to women wanting to start HRT. So in some ways you can see GP's reluctance just to prescribe HRT, because there are risks, but at the end of the day, it's a balance of the risks. People also ask, how long can I take HRT for? How long should I take HRT for? And there is no right or wrong answer for that. The breast cancer risk with HRT persists even after you stopped HRT. So if you've got a family history of breast cancer, or you yourself have had benign breast disease, then it's something that really needs to be discussed in more detail with your GP, or go to the menopause service.
That's really useful. Thank you. Another question in the chat. So I think this is quite an important topic that not many ladies do talk about. So we have one lady who is currently taking steroids. However, she wants to try and increase her libido. So she wondered whether she could have estrogen even though she's on steroids.
I don't see that there's an absolute contraindication to using HRT and steroids, but I could certainly find out if you want to email me. I'm not aware that there's an absolute contraindication. I think with a lot of these things, it's exploring other ways, isn't it? Yeah.
Brilliant. No, that's great. Thank you. And
I think the other thing about the sort of libido side is, is it really libido? I'm not saying for this particular person who's asked the question, but, is it because you've got dry vagina, things are uncomfortable, so it actually puts you off just the thought of having intercourse because it's not that enjoyable anymore? So it's a way of saying, well, you know, can we find ways to make intercourse more comfortable? You know, you can use vaginal estrogen rather than full-blown HRT. There are vaginal moisturizers on the market that you can buy over the counter without prescription. So Hyalofem or Replens are good non-hormonal vaginal moisturizers. And lubrication during intercourse. KY gel is not that great, although everybody knows about KY gel or Optilube, but actually using Silk, spelled SYLK, or Yes, that's a bit of a corny name, YES. Yes, make a range of lubricants, they make vaginal moisturizers, and the actual texture of these lubricants are nicer than using KY gel. They're kind of much more, they're water-based and much less tacky, shall we say. And because they're water-based, you can, are you recording this, Claire?
I am, yes.
You can use them with any sex toys too. So they don't interact, and it's fine. So you don't have to, you know, worry about disintegration of any things that you're using.
That's great, and thanks for that question, because I think it's really important that we talk about it, and I think a lot of ladies are a bit frightened to ask, so it's really, really useful, and I'm sure lots of people got a lot out of that answer. Another question is around, one lady has put in the chat that she was told that she started with the menopause early because of the fertility treatment she was having. Is that true?
That's a tricky one. So why do we get to the menopause? So that we get to the menopause because basically our ovaries run out of eggs. So we are all, so the number of eggs that every single woman, is allocated in life is set at the time that when we're, even before we're born. So whether you've got more eggs, less eggs, there's really nothing you can do about it. And the ovaries are programmed to, I use the word die in a very kind of loose way. The ovaries are programmed to stop functioning, I should say, or stop producing eggs way before. So this is assuming that you're not taking medication to stop the ovarian function, you're not being given chemotherapy or anything like that, that will cause the ovaries to stop functioning earlier. So in theory, if you've undergone or had a lot of medication to super ovulate the ovaries, then in theory, the ovaries could run out of eggs sooner, but it's not that common. I wouldn't say it can't happen, but it's not that common. So women who go through an early menopause, their ovaries basically go through the same process as someone who's going through a late menopause. It's just at a much earlier stage. So the actual process is the same, whether you're 30 or 50 or 40 or 55.
Brilliant, thank you. A couple of questions in the chat. Can we increase our estrogen levels naturally rather than using medication or HRT? Is there any way of doing that?
So there are estrogen-rich foods. So we talk about soya-based foods. We talk about things like yam. Some seeds contain estrogen. I think the difficulty for us, where, you know, tofu, soya, yam is not really part of our everyday diet. So to change a diet to increase all those foods is not that easy, I suppose. But those are more so foods that contain estrogen, so isoflavones, really. I think there's a bread brand, Burgeon, I think it's called, where they have lots of linseed, sunflower seeds and things like that. So well, we jokingly call it the menopause bread, but it's got seeds. So you could increase linseed, for instance, in your breakfast cereals, or have more soya. Think about using yam a bit more. But to eat it every day, maybe your families will probably object, I suspect.
Definitely. And I'm not sure what this is. So it may still be on the topic of natural remedies. If not, please explain it to everybody. So somebody's popped in the chat. What are your thoughts on Agnus castus?
Yeah, so Agnus castus has kind of gone out of fashion a bit. So it was very, very, very popular. It's not really an HRT, but a lot of people use Agnus castus to treat the more emotional side of symptoms from the HRT. And some women find that does help with their menopause symptoms, but it's not estrogen as such. Yeah. I think somebody was on about Menopause as well, and Menopause is red clover, which is isoflavones, I think. So again, if you like, it's natural HRT, except it's not really HRT.
Okay, brilliant, thank you.
Someone said about thyroid issues, and so common, I think, hair loss, weight gain, feeling tired, dry skin are also menopausal symptoms that a lot of women describe. And those symptoms do overlap with someone who may have a thyroid, an underactive thyroid. So your GP may want to check hormones in that situation, depending on the kind of whole array of symptoms that you may be describing. So whilst I say that you don't need to really have your ovarian function tested, I think depending on your specific history, your GP may want to check your thyroid and want to check that, your FSH is normal or isn't normal. But as long as you've excluded a thyroid problem and your GP's happy or you're happy it's not thyroid, you don't necessarily have to have a very, very raised FSH and a very, very low estrogen to start HRT.
Okay, and just to mention, everyone, just keep the questions coming because we do have plenty of time. I'm trying to group them together as best I can because there's quite a few that are the same.
Can I just a word of caution, I suppose, that if your HRT isn't helping your sleep or isn't helping your moods, and your family have all moved out because you're so terrible every day or whatever, then I think do bear in mind that it may not be the menopause, that actually then looking at your mental health and things like that will be just as important. I think that it's very easy for us working in healthcare to accept that perhaps we do need help for mental health. So it's easier to say, oh, I'm in the menopause, I'll take HRT, but actually I don't feel that great. I still don't feel that great. And I'm still crying and shouting and not sleeping so well. So I think do bear in mind that it may not be the menopause. That's what I would say.
Brilliant, thank you. I'm going to jump back to HRT. There's a couple of questions coming in, and I wonder if it was around the breast cancer question. So I'll try and group them together as best I can. So firstly, are the patches less risk when it comes to HRT, and do the benefits really outweigh the risk, in your opinion?
Sorry, what was the first part of that question?
So are the patches less of a risk?
In terms of clotting, yes. So I would say it doesn't suit everybody, but the transdermal route, whether that's a patch or a gel, seems to be generally at the moment better, safer, shall we say, because it bypasses the liver and all that. So it is meant to be safer, but it doesn't suit everybody because the patches can cause quite an allergic reaction. So for some people, they just can't get on with the patch because they have terrible angry rashes. It doesn't stick for some women. It just does not stick. Don't know why. It's not supposed to fall off, but for some women, you know, I've seen women sticking it down with plasters and bandages and all sorts because it just does not stick. And yeah, so I think it may be the way to start, but it may not be the way that you end up taking your HRT. I can see someone's asking, does HRT just delay the symptoms? Sadly, yes. So when eventually you stop HRT, whether that be at the age of 60 or 65, I've got 70-odd-year-old women on HRT, because when they try and come off HRT, they say they get the symptoms quite severely. But I think, again, you've got to ask why you're starting the HRT, and at the outset decide how long. Just, you've got to be honest with yourself and say, well, how long am I going to continue on HRT?
That's that, and that goes into my next question, actually. So somebody's asked, if you just stop taking your HRT for whatever reason, would your symptoms just all come back?
Yes. Unfortunately, yes.
It's a nice, clear answer. Can I go back to the one around the risks? And I know you've touched on it, and I know it's very personal to each individual and their history and things, but there's a couple of questions around, if you've got family history. You talked a little bit around, if you had a breast cancer scare and things. So I think what people are really asking is, in your opinion, I know you might not be able to answer it generically, but does HRT really outweigh the risks of cancer and other things? Is it recommended?
I think it's a very personal. I think it's a very, very personal very personal decision. I know that in our trust, the breast surgeons who deal with the breast cancer and the oncologists are really not very happy for us to prescribe HRT. And probably not even use the Mirena. So whenever we've asked them, whether we can put a Mirena in somebody or use HRT, they've mainly been unsupportive of using HRT in someone who's had breast cancer. Someone with a family history of breast cancer, I think that's different. You'd need to weigh up the risk. You need to find out, what the sort of background, do a kind of almost family history. How many other people have had the breast cancer? Is it down the maternal side, paternal side? Is it your grandmother, your mum, all your aunts? In which case your breast cancer, your risk, and, genetically, you may be advised to have BRCA gene testing and things like that. But if it's a random aunt or someone who's had breast cancer at a very late stage in life, then that could have just been a random, spontaneous sort of breast cancer. So that doesn't mean that you can't have HRT. So I think that needs to be decided on a very individual basis.
I suppose it's about doing your research, isn't it? And knowing what's
and having that conversation. If you've been offered early mammograms because of your family history of breast cancer, then I would say quite naturally your GP is not going to be happy to prescribe HRT, and quite understandably. So that becomes a specialist referral, because you've been having mammograms since the age of 40 or something because of a family history. I think the other thing is to encourage, I would strongly encourage people to, if you're over 50, you've been invited for a mammogram, go and have a mammogram before you embark on HRT, and just have that conversation, with GPs or get referred.
Yeah, thank you. Another question, can estrogen replacement have an effect if there is a history of fibroids?
So in theoretically, fibroids can get bigger if you're taking estrogen hormones. So again, it depends on how big the fibroids are, how many fibroids, how long they've been there. So there are a lot of women who choose to have HRT even when they've got fibroids. But bear in mind, if you've got fibroids and you have had very heavy bleeding because of the fibroids, then HRT could aggravate that, all the, the bleeding and all that as well.
Okay, thank you. I'm just having a little scroll down. So, somebody's popped in the chat. So if HRT is just kind of a stopgap and it postpones things, is there a place for antidepressants, do you think, for some of the other symptoms?
Again, I think that's a very personal thing. Because if you start antidepressants, then when would you stop it? That's the thing. And I don't think there's an easy answer to that one.
Yeah. Okay.
Someone's just asked about age and still having regular periods. Should I be able to have HRT? The answer is yes. Having regular periods is not a reason why you should not have HRT. It's really your symptoms.
Yeah.
HRT linked to breast cancer is true, most definitely true.
There's another question in the chat, and this is kind of common what we're hearing from staff members at the moment is somebody's gone to their doctor and the doctor has said come back when the symptoms get worse, but this person feels like they're managing their symptoms at the moment. When does it become a point where they need to maybe consider HRT or other treatments?
I think some people choose never to use HRT, and that's absolutely fine. So if you think you're managing by regular exercise, a good diet, doing mindfulness things, and your family and at work, everybody, is supportive. If you have a tearful moment, that's absolutely fine. You do not need to take HRT. So HRT is not compulsory, and it's not really a cure all. So I think it's important to say that HRT will mostly make menopausal women feel better, but it isn't going to make you 100% better. So you can never feel like you're 21. I think that's very important to realize. So your joints will still be sore. You'll not be able to keep up with your teenage children, and you probably will still not sleep as well as you used to do, but it's a help. So, which is why I think at the outset, if people are taking HRT, you've got to be honest with yourself and say, why am I taking this HRT? Is it for libido? Is it to help me go to work? We're all in very pressurized jobs, more so these days. Is it just helping us to be able to do the work that we do? And when we retire, we can say, actually, it doesn't matter if I only slept 3 hours last night, because I'm not having to go to work at 6 o'clock in the morning. I'm not having to do a 12-hour shift. I'm not having to be on call for the next 24 hours. And it's fine. I've not slept very well, but I know that I can take it easy, and I'm not going to go shopping today. I'm going to go shopping tomorrow. So I think it's very, very important to be honest when we all start HRT is, why are we taking that HRT? It's not an elixir for youth. I think it's got a very important part to play, but it's not going to reverse the clock, I would say.
Yeah, that's a very good point. There's a lady popped in the chat that she doesn't really want to take HRT because of some of the risks, but her GP has advised her to do so for the bone protection benefits. Is there anything else or any advice you would give to her instead of HRT?
Yeah, so I would say, what is the bone protection? I mean, so is there a history of bone thinning already, or is this a just in case sort of scenario? Is there a family history of osteoporosis, osteopenia? So I think that you just need to find out a bit more about the bone thinning, get a bone density scan if your GP is really worried, or perhaps you yourself have been taking long-term steroids and all that sort of thing. Then there are other things to help with bone density, not just HRT.
So she's put that it is bone thinning in the chat.
Yeah, so there might be other things that you can take and not just HRT. So stopping smoking is an important one for bone thinning. Reducing steroids. Smoking is bad for bones, for sure. And weight-bearing exercises are important. So swimming isn't probably a great exercise for maintaining bone density.
Okay. I think, apologies if I've missed any questions in the chat that I've not asked or you don't feel has been covered. Those that have arrived late, we have recorded the session. I haven't asked your questions just because we've already asked them maybe, but if there's anything that I've missed, please copy and paste and pop them in again. I'm just having a look at this last one.
I think someone said, is low estrogen the cause of low libido in the menopause? Largely so, yes. So no one's asked me about testosterone, interestingly. Perhaps people didn't want to. So
cover that as well, though, Dr. Tay. Maybe just people not really understand.
Yeah. So I think that two schools of thought. Some people believe that we need testosterone to increase libido. I think testosterone doesn't just increase libido, it increases your aggression. It's got risks in terms of acne, hair growth. It's testosterone. We are not able to prescribe testosterone really on the NHS now. It just is not available in the UK. And we don't believe that really we need to prescribe testosterone or give testosterone as part of HRT. So you'll find that you just can't get HRT. And I don't actually believe we need to prescribe testosterone, sorry. So there may be lots of chats. I think social media, I'm not part of social media chats for these. There may be people saying that, get testosterone. The only testosterone you can get now in the UK is, I think, limited to treating male patients. And then the rest you just have to buy online. Most of it comes from America, really.
Okay.
Somebody's using CBD oil. I've heard that as well. And some women have reported good things with CBD oil. I don't know much about it.
Is there any other questions, Benny? We've got Dr. Tay now for about another 10-15 minutes. If there's anything you think we haven't answered or covered, and likewise, Dr. Tay, if there's anything that you think that is quite important that you would like to mention or talk about, please feel free to do so.
I would say the British Menopause Society website is a trusted website. I'm not saying the rest are not, but one that we would go to, for a balanced view, shall we say.
So Karen's put in the chat, and I know we've covered this briefly already, but should you have a blood test pre-commencing HRT? So we talked about getting blood tests, didn't we, to get a diagnosis? Would you recommend having a blood test before going on HRT?
Say that again, having a blood...
Would you recommend having a blood test prior to starting HRT?
No, not absolutely compulsory.
Will not taking HRT have a negative impact? I suppose that's if people are not managing with their symptoms. Do you feel it would be a negative impact, or is it still very much a personal choice?
Sorry, I'm just reading some questions. I missed that.
So will not taking HRT have a negative impact?
No. I mean, some people choose to just go through the menopause naturally. Some people feel they want to keep their energy levels going a bit longer, maybe better skin, less dry vagina, less low libido, just being able to concentrate better, sleeping better, because they are still working full time. So I think it has those benefits. It does protect the bones, but as I said, I don't think it's the only reason you should be taking HRT. I think it's a change of balance when we where it's the low estrogen. Someone asked, is it the low estrogen that causes the menopausal symptoms? It is the low estrogen and low progesterone. So even if you just took progesterone, it can have some beneficial effects.
Okay, lots of questions now coming in, which is great. What would you recommend to a patient who was struggling with joint problems? We're going to talk a little bit around exercise later on today.
Yeah, I think there's lots of reasons for joint problems. Maintaining mobility, keep doing exercises, and but lots of, and I think there's using turmeric and ginger for people who don't want to take HRT for joints. There is some evidence, I think, out there for using turmeric as an anti-inflammatory, and ginger as an anti-inflammatory, if you don't want to take painkillers either.
Is having a dry mouth part of the menopause? And if so, what would be a recommendation to avoid that?
I'm not aware that it is.
Okay.
And yes, a lot of women say they put on weight when they're in the menopause. That seems quite common. I don't really know what the physiology is behind that. But yeah, your weight may not change, but your body shape does. Does that make sense? So, yeah, it just redistributes, shall we say.
And in terms of low mood, if your GP is putting you on HRT and antidepressants at the same time, would your recommendation be a staggered approach? How would you know that which one is being effective?
If your GP's put you on
antidepressants and HRT at the same time, how would you know which one's the one that's working?
I don't know. That's a good one. That seems to have covered all bases, your GP.
Yeah. So I suppose maybe the answer would be to try a staggered approach, would it?
Yeah, I think you shouldn't stop I don't think you should stop your antidepressants suddenly, because you're not meant to. You're meant to wean yourself off the antidepressants, isn't it? I mean, it may be that the GP's thinking the mood side is quite significant, so therefore antidepressants and HRT to really get them, improve the moods. And then it's a question of which one, because the HRT will probably have beneficial effects other than mood. So it's all the other things, isn't it? Someone's asked a very relevant question, saying, if my periods have stopped for a year, does that mean they are not going to return? Depends on what your age is and why we think your periods have stopped. So if periods resume after 12 months or more of no periods, then, and you think you're menopausal, then actually that's a red flag symptom. And you really must see your GP and be referred into any hospital on a 2-week pathway. So that's really important to know. So we're moving sideways a little bit now, Claire. If your periods have stopped for a year and you think you've been menopausal and your bleeding starts again, you must see your GP. Okay, I think even if you've been taking HRT for that year and you've had no bleeding for a year and your periods suddenly return out of the blue, you need to see your GP.
Yeah, that's useful advice. Thank you. Another question, which is quite relevant actually, when we've talked about actually it's not, your periods don't just automatically stop and that's not the first symptom that you notice. So someone's popped in the chat that they've been struggling with their mental health for quite some time now. So how would they know, because these symptoms are obviously very cross-cutting, how would they know if they're menopausal or whether maybe they aren't?
I think that the menopause can worsen your mental health. So I think if mental health issues has been in the background, however severe or mild it's been, then actually the menopause can make it worse. So I think if anyone's noticed a deterioration in their mental health, you need to go and speak to your GP, have an honest discussion. Is this my mental health? Is there something, do you need a bit of exploration? And in that situation, I think it's one of the situations where I would suggest that maybe check your hormones, because you don't know. But if you've been previously well, you now get to a stage where you think, yeah, I'm probably in the menopause and I'm tearful, I'm shouty, I'm not coping, whereas previously always coped, always been fine, in control, and suddenly not in control at work, at home, whatever, then yeah, that is possibly more likely to be menopausal than just mental health. But mental health deterioration can hit us at any time, can't it?
Yeah,
Not
absolutely.
just around the menopause.
I suppose it's noting what's going on around you, what you're going through at the moment, and if things haven't really changed in terms of your environment and work-life balance and things like that, then maybe that is a flag to notice that it might be the menopause.
I
Brilliant.
think one useful exercise is actually just to keep a diary. So, menopause, mental health, and premenstrual issues, PMS. It's important to keep a diary. And we often ask women who think they may have PMS or PMDD to actually keep a diary and say, is there a pattern? Is there a cycle? Is it premenstrual? Is it mid-cycle? What is it for those of us who are still having periods? I think it would be good even for yourselves to know, but your GP would certainly ask you, or should ask you. So if you just have an app or just putting it in a book, a notebook, whatever, just noting down, what's the day been like? What's it been like at work? How did you feel? Not sleeping well, even a food diary. So alcohol and caffeine will definitely make your menopausal symptoms worse. So if your sleep is bad, you have a binge drinking night before, your sleep is definitely going to get worse. And your flushing is going to get worse. So if you get palpitations, you feel anxious, then actually cutting down on caffeine is something that we should all do.
Yeah, definitely. Really interesting question gone in the chat now. So somebody's got a Marina coil, which they've been told to leave in indefinitely, even though it was due to be changed a year ago. She thinks she's menopausal. How would she know when to go and ask for that coil to be taken out?
So Marina companies recently changed their guidance. They used to say 5 years for the Marina coil, and I'm not sure whether it was really COVID driven or whether they've done the evidence, got the evidence scientifically. They now say you can keep the Marina for 6 years. And I would say that if you've had it for 6 years and you're probably over the age of 54, then you can take it out. So contraception in the menopause is a very interesting area. You need contraception for at least a year after your last menstrual bleed. So because it's all retrospect, isn't it? You think, oh, I've not had a period for 6 months, I'll not use contraception. Technically, we would say you shouldn't stop your contraception. You need to use contraception for at least a year after your last period. So it's tricky if you've got the Mirena and you're using it for contraception, you've not had a period for 5 years, then that's a tricky one. I would say keep it till you're 54.
Yeah, that's
I mean,
really
the hormone bit of it will probably run out by year 5 or year 6, but the actual device, just having a foreign body in the uterus, will be sufficient in someone who's 50 or in the early 50s, will be sufficient contraception even without the hormone. But your periods might come back, I suppose, once the 5 years runs out, because the hormone bit of it doesn't last forever.
That's really useful. I am actually going to call it there because it's 22 and I don't want you to be late, Dr. Tay. So I hope you've all found that really useful. I know I have. And thank you so, so much, Dr. Tay, for taking time out of your busy schedule today to come and talk to us. And a lot of talking you have done. So massive, massive thank you for doing that. We have recorded it as well. So for those that maybe didn't miss the start or have colleagues and friends that wanted to join, we will be sending that out as well. So once again, lots of thank yous coming in the chat as well. Massive thank you. Really appreciate your time with us today.
We'll probably do it again, I guess, if we, yeah.
You're more than welcome to come to any of our support groups. You can take over from me and give me a rest because you are much more suited to do it. But yeah, no, absolutely. Thank you. I really appreciate it.
Yeah. Good. Have a good rest of the meeting.
Take care. Thank you so
Thanks.
much.
Bye now. Bye.
Let me just stop recording. And then what we'll do, guys, is